fellow one who runs the medical stores, even he also gives counter sales of medicine. But diagnosis, a key factor. It is cultivated, one's own. It's like it's not given, it's not Diksha ki take diagnosis, finish, not the case here. It is repeated adhyayana, repeated observations will make you perfect. Hence, my initial half of talk will be, I am focusing on how to diagnose the conditions because that's the key. Unless and until we diagnose correctly the Vyadhi, the Vyadhyavastha, the Srotas, the Samprapti, the Vyadhi Ghatakas, it's immaterial the knowledge of medicine what we have. Hence, hitting the Samprapti, the right chikitsa is Samprapti Vigatanam Eva Chikitsa. We strongly believe in Samprapti, Dosha, Dusha, Agni, Am and Shrotas, the Vyadhi Ghatakas. And whatever treatment we design, we plan, we have to target on these five factors. Dosha, Dusha, Agni, Am and Shrotas. In this view, I am discussing the disease. Next. Next slide. Next. Yeah, Roga Madhav Pariksha, Tato Antaramausha. Wherever I go, I begin with this shloka because this is the fundamental. I am a strong believer of Yukti Pramana. We have Chaturveda Pramana stored in Ayurveda. Pratyaksha, Anumana, Apadesh and Yukti. Yeah, Yukti. You should have good Yukti. Yukti is one's own like deliberations. Pratyaksha, Anumana and Aptoba, the Apta knowledge. And based on these three factors, we have to develop our own skills. I believe Yukti is a skill one has to cultivate in or corporate. Next. Yeah, today I am discussing different hepatobiliary diseases. In Ayurveda, Raktavaha Srotagata Vikara, that too Yakrut Pliha Janya Vikara, and that too I am highlighting Kamala. I think the picture is telling you many things. It is for students. This picture is basically for students where to observe icterus. What is icterus? It's a yellowish discoloration of sclera and mucous membrane. Netra Nakatva Pitata has been told in Pandu Kamala Adhyaya, Varna Vikruti Janya Vikara. Pandu Kamalar, Varna Vikruti Janya Vikaras. What kind of Vikruti Varna the patient is going to achieve? These are the abnormal Varnas. My dear students, whenever you get such patients, don't see only eyes. You have to see what is icterus. Icterus is nothing but yellowish discoloration of sclera and mucous membrane. This is sclera. What is mucous membrane? This is the dorsum of the tongue. And the palate. You see the palate. These are the areas. And the nasal mucosa. It's not visible clearly here, but whenever you get dark icterus patients, these are the areas one should focus to diagnose. Hence, jaundice is nothing but yellowish discoloration of sclera and mucous membrane. What is Ayurvedic understanding? Kamala. The word Kamala is having two meanings. One is with respect to desire, second is with respect to the Varna. Harana Chandra, ancient scientist, I can say, he defined Kamala as Kama iti sadharana shabdaha vishesha swalpe bhaktabhilasha pravartante. Kamala is a condition wherein the person is going to lose desire towards all the aspects. Swalpe bhaktabhilasha. Bhaktabhilasha is not eating or hunger. It is a abhilasha. It is inability of Ekadasha Indriya Karma. The Ekadasha Indriyas are not functioning properly. Swalpe bhaktabhilasha. Hence, it's a classical definition told by Harana Chandra, Swalpe bhaktabhilasha pravartante. The another definition with respect to Varna, Kamalaha Kanti lunati hinasti. Kanti, generally Kanti we believe in luster, the Teja. But in this context, the Kanti can be interpreted as Varna. The person who is suffering from this abnormal condition, he is going to lose the normal Varna, he is going to attain abnormal Varna. See, so scientific the definition. I will tell you scientificity of our acharyas in each and every step. The first step with respect to definition, see who is more scientific. In a single word, they could able to say all the clinical features of a disease. Swalpe bhaktabhilasha pravata, single word they could able to say. It is our knowledge to interpret in what way, in what direction we can interpret. And second is with respect to Varna. That's how Ayurveda believes Kamala, and what modern people believe jaundice. I go simultaneously both the both. I'll discuss both the sciences simultaneously so that it becomes easy to understand what our Acharya has been told, and I want to prove how scientific they were. Now, hepatobiliary, because today's topic is I am supposed to discuss about hepatobiliary disorders. In modern science, it's very easy to make out what are hepatobiliary disorders. The diseases belong to liver and biliary system. Liver and biliary system, the diseases, they have got their own systemic chronological discussion discussed in their respective texts. It's not so in Ayurveda. We have to search here and there based on the findings, the explanations, and we have to enlist. And I tried my level best to list out what are the different diseases, conditions discussed by our acharyas under the heading called hepatobiliary disorders. Now, Pandu, Kamala, Halimaka, Kumbhakamala, Panaki, Yakrit Roga, Pliha Roga, Udara, Raktapitta, Madateya, and so on. You can add few more to this. I hope there shouldn't be any doubt as far as addition is concerned. I can give substantiation for each and every condition why I added. For example, Raktapitta. You may ask, Raktapitta, no doubt it's a Raktava Sodota Vikara. It is a bleeding disorder. It's a bleeding disorder, that's why I added, because in case of chronic liver disease, the most important clinical feature which we see in practice are the bleeding. Bleeding is not stopping at all. There's no coagulation because of high PT. Prothrombin time is very high because liver has stopped functioning because of the illness. No coagulatory factor synthesis, hence the PT level, the prothrombin level will be high. More the PT, the chances of bleeding will be more. But what is the relation between Raktapitta and this? What is Raktapitta definition? I want Ganana Sen Siddhanta Nidana definition. Vinabhighata, Sputakaranatvat. See, Raktapitta, see, bleeding is, all bleeding are not Raktapittas. All bleeding, if cut wound happens and bleeding starts, is not Raktapitta, my dear students. Vinabhighata, without any abhighata bleeding. Sputakaranatvat, no traceable reason for the bleeding. That is Raktapitta. That is Raktapitta. No traceable reason for that is a spontaneous bleeding without any reason is Raktapitta. Hence, bleeding is common conditions in Raktapitta, and bleeding is one of the important features seen in chronic liver disease. Then I made this, I thought ki, let's include Raktapitta also in this group. One interesting thing, we keep on telling Ayurvedic people, we don't have any side effects, blindly you take any drug. If you ask anybody, oh, it's Ayurvedic drug, why you are worrying? No complication, no side effects, aram se you can take. No, it's not so. Even in that era, Sushruta's era, he could able to trace our drugs are toxic. No doubt, Bhallatak is very toxic. You all are aware of that. But in the context of Raktapitta, Sushruta, while discussing Raktapitta, Dallana, while commenting on Sushruta's version, he opined there is a kind of Raktapitta called Aushadhi Kruta Raktapitta. One of the Nidana for Raktapitta is Aushadha. Amazing. Amazing. They could able to sense the Aushadhi can cause Raktapitta. And there are two important drugs he mentioned. Anybody? Apamarga and Jyotishmati. If Apamarga and Jyotishmati, they are used without any supervision, that can cause Raktapitta. What it may be? It may be hepatotoxic. It may be hepatotoxic because it is inducing Raktapitta. It is inducing bleeding. It's not one day two administration, no. Years together, without any supervision, without seeing the Prakriti, without seeing the thing Kala, Prakriti, Vaya, Bala, Vaya, Kala, so on. Without seeing those, if you administer, that can lead. This example. Hence, coming back to this, Pandu, Kamala, Halimaka, Kumbhakamala, all these are Avastha Vedas of Kamala, Kumbhakamala, Halimaka, etc. All can be included under the heading called hepatobiliary disorders. In Ayurveda, we can call Raktavaha Srotogata Vikaras. Raktavaha Srotogata, there are many more, even Kushta also Raktava Sotas, but Raktava Sotas with respect to these, like Ranjaka Pitta Janya Vikaras. I will discuss Ranjaka Pitta then in the next two slides. Next. Now, Ranjaka Pitta. What is Ranjaka Pitta? It's amongst the Panchapittas. Amashaya Ashritam Pittam Ranjakam Rasaranjanat. Very famous first BMS in Sharira Kriya, you had this shloka. Amashaya Ashritam Pittam Ranjakam Rasaranjanat. No, no, it's correct. It is a pitta which is there in Amashaya, which is helping for the rasaranjana. In turn, it is going to produce rakta, hemopoiesis, erythropoiesis. We can call the name. Rasaranjana is hemopoiesis. Rakta is, don't be limit your knowledge of rakta only to the RBCs. It is total rakta. RBC, WBC, platelet, everything. Everything. Hence, the production of blood cells is Ranjaka Pitta Karma. Amashaya Ashita Pittam, Ranjakam Rasaranjana. This is what we have understood. If you see the Kamala Samprapti discussed by Chakrapani, while discussing Tilapishta Nibavarchaha, he opined it happens because of Kostasya Malaranjaka Pittasya Abhavat. There is another Ranjaka Pitta called which does Malaranjana. Now we have two Ranjaka Pittas now. One is Rasaranjana, second is Malaranjana. The one which does Rasaranjana is erythropoiesis. The one which does Malaranjana is bile. We can consider Malaranjana Ranjaka Pitta as bile in general. Bile contains three components: bile salts, bile pigments, and bile acids. And we know the pigment part in the bile is bilirubin and biliverdin. They are responsible for some pigmentations. I am discussing in Samprapti. This is Malaranjaka Ranjaka Pitta. Hence, you can think further now. We can classify Ranjaka Pitta is of two types. One is Rasaranjana Ranjaka Pitta. Second is Malaranjana Ranjaka Pitta. Rasaranjana Ranjaka Pitta, we can say essential factors for the production of the RBCs. Malaranjaka Ranjaka Pitta is bile. Next. Classifications. Now we saw Kamala is jaundice. It can be comparable. Now we saw the definition. We saw the pathology. Now in brief, now we see the classifications. Charakacharya is the first person to classify Kamala into two types. He is the only person who classifies a pioneer. He opines Kamala can exist in two forms. One is Koshta Shakashita Kamala, second is Shakashita Kamala. Next. One is Koshta Shakashita Kamala and Shakashita Kamala. I'll discuss in detail how they have been named. Go in depth why it has been named Koshta Shakashita. There are two words, Koshta Shaka, one is only Shaka. It is the presence of Pitta, the dominancy of Pitta in which area the respective name has been given. Here Pitta is Ranjaka Pitta. Ranjaka Pitta is bile. Where bile is dominate, if it isn't dominating in Shaka, it is Shakashita Kamala. Shaka iti Raktadayastvak. I hope you have understood the meaning, basic meaning of the Shaka, what you have learned. It is a periphery. We call periphery as Shaka. If bilirubin is settled in periphery more, it is Shakashita Kamala. And why it goes periphery, we will discuss in Samprapti. If the quantum of Pitta available in Koshta more and little in Shaka, it becomes Koshta Shakashita Kamala, because the majority of Pitta is settled in Koshta itself and very little amount has been gone to Shaka. Hence it is Koshta Shakashita Kamala. Hence it's a what we can say, it's a Charaka's opinion, how we can interpret. The word Shakashita and Koshta Shakashita have been coined based on the quantum of bilirubin where it is dominated, where it is more settled, and based on the respective name has been given. Next. Now, the modern classification, I mentioned here, I will go both simultaneously. Ayurvedic understanding, Charaka is the first person, Charaka is the first person, and remaining Acharyas have copied Charaka's version. They have copied Charaka's version, they have produced the same. But that's why we say Charaka is the first person. The modern classification. In modern, the Kamala is classified, jaundice is classified different ways, but to make it very simple, I consider it is of two types. It is of two types. One is pathophysiological classification, second is etiological classification. The jaundice is of two types. One is pathophysiological, second is etiological. As per pathophysiology is concerned, it is further of two types. One is predominantly conjugated hyperbilirubinemia. The second, predominantly unconjugated hyperbilirubinemia. Now, What is bilirubin conjugated and unconjugated? Two new terms we are learning now. I hope bilirubin, everyone is aware of what is bilirubin. It is the end product of RBC destruction. As we know, each and every cell in the body is having its own lifespan. Like that, RBC is having its own lifespan. Once it attains its maturity, it is screened, it is sidelined, destroyed. 120 days. Once 120 days achieved, RBC is destroyed, and as a process, we get pigment part and protein part, heme and protein, and the further iron, bilirubin, and albumin protein are reduced, and they are reused. The bilirubin which is produced immediately after destruction of RBC is called unconjugated bilirubin. It's also called indirect bilirubin. The bilirubin which is produced immediately after RBC destruction, it is highly toxic. It is not water soluble. It's fat soluble. The unconjugated bilirubin is very toxic, not water soluble. What body does with toxic material? It detoxifies, expels it out. Is it not? Excretion. Body doesn't want to retain which is not useful for it. Same thing with unconjugated bilirubin. Bilirubin is having not at all any function. But poor body cannot excrete it. Why? It is not water soluble. All excretory media in the body are aqueous. You take sweat, urine, stool, all these are aqueous. Hence poor body cannot expel it out. What body wants? It's conversion. It's conversion. From what? From the process wherein the fat-soluble bilirubin is converted into water-soluble bilirubin is called conjugation. Is called conjugation. What is conjugation here? The fat-soluble bilirubin is converted into water-soluble bilirubin. Hence, conjugated bilirubin is called water-soluble bilirubin. It can be easily eliminated because it has been converted. This is the basics. See, what is jaundice first of all? Just now I told icterus. What is laboratory definition of jaundice? Jaundice can be defined as hyperbilirubinemia. The another definition for jaundice. Jaundice is nothing but hyperbilirubinemia. What diabetes? Hyperglycemia. What gout? Hyperuricemia. Like that, each and every disease having its own laboratory definitions. What my point here? Laboratory definitions. The laboratory definition for jaundice is hyperbilirubinemia. The bilirubin level is supposed to be 0.8 milligram per deciliter, 0.2 to 0.8 milligrams. When it exceeds the upper range, that is called hyperbilirubinemia. If it exceeds 2.5 grams, then only clinically it is evident. I'm discussing in LFT. I'll discuss in detail about that. But make it a point, if bilirubin level high, that is jaundice. Now, this high bilirubin can be of two types. Now, coming back to discussion. One is, if conjugated bilirubin is high, it is predominantly conjugated hyperbilirubinemia. If unconjugated is high, predominantly unconjugated hyperbilirubinemia. This is two classifications. And why it occurs has been told in the chart here. If you see unconjugated bilirubin, the reason for this, one is overproduction of bilirubin. What is overproduction here? Excessive destruction. As I mentioned, RBC undergo destruction after once it attains a maturity. Here destruction can be of two types. It's not told in classics, but practice made me to think in this way. Destruction can be of two types. One is physiological destruction, second is pathological destruction. RBC can undergo in two ways its destruction. Physiological means once it attains maturity, it is destroyed, no doubt. It's a normal process. But sometimes it so happens, even though it is not matured, it is young still, but still killed. Some pathologies, malaria, best example I can say malaria, some Rh incomplete disorders where very rarely we see. In this condition, what happens? The RBCs are destroyed in excessively, and there is no more production of unconjugated bilirubin. Hence, that's one of the reason is excessive production. The next, impaired conjugation. I mentioned here, conjugation is the process converting bilirubin into fat into water-soluble bilirubin. It takes place in hepatocyte. The process of conjugation takes place in hepatocyte in presence of enzyme called glucuronic acid. 6 molecules of glucuronic acid, 1 molecule of bilirubin come together and process takes place. If glucuronic acid is absent or minimum, Even that also can lead to condition called unconjugated hyperbilirubinemia. Even though all LFT parameters are normal, only unconjugated level is high. It can be a, once again, because of improper conjugation, which we call in practice as Gilbert syndrome. You might have heard about Gilbert syndrome, a rare clinical condition seen in practice. It is this condition. Unconjugated bilirubin is high because of absence of glucurononic acid called Gilbert syndrome. The next, reduced hepatic uptake in case of some hepatotoxic drugs. Hepatocytes are not functioning properly, hence this can occur. Hence these are the three important reasons for increase of unconjugated bilirubin level in the serum. The second, predominantly conjugated hyperbilirubinemia. Here, no problem with production, no problem with conjugation, no problem, everything is fine, but still bilirubin is high, it's conjugated. Once the conjugation process takes place, what is the next step? It has to be excreted. And where it is excreted, the conjugation process takes place in the hepatocyte. Just remember the histology, the students. The hexagonal hepatocyte, in between two cells, there is aperture. The first aperture for the excretion of the bile, that's called bile canaliculi. The bile canaliculi is the first aperture for the excretion of the bile. If anything obstructing the flow of the bile will lead to conjugated hyperbilirubinemia. Hence, here the main reason for elevation of conjugated bilirubin is, one is decrease intrahepatic obstruction or extrahepatic obstruction. Now you can make out there are two important causes. One is destruction, second is obstruction. I hope this is a take-home message for students, and this is a lifelong message for you people when you are treating jaundice. First point one should see, is it destruction or obstruction? The given condition is destruction or obstruction. Based on that, the treatment will be decided. The main treatment of all liver disorders are based on these two important things. This is the important understanding point. Is it destruction pathology or is it obstructive pathology? Next. The second classification, just as I mentioned, modern jaundice can be understood in two ways. One is pathophysiological classification, second is etiological classification. Based on etiology, the jaundice is of three types. One is pre-hepatic jaundice, second is hepatic jaundice, third is post-hepatic jaundice. I hope pre, post and hepatic. Pre-hepatic prior to liver. Pathology prior to liver, which is reticuloendothelial system, which is responsible for the destruction of normal RBCs. If something excessive destruction will lead to excessive production, already we saw the first line classifications. That is pre-hepatic jaundice. Second is hepatic jaundice. If the pathology is in the liver only, that is called hepatocellular jaundice or hepatic jaundice. The third, post-hepatic jaundice. Neither the pathology is before nor in the liver, it is away from the liver. It is away from the liver means what? Right from porta hepatis till the ampulla of Vater. Just imagine the anatomy. Right from porta hepatis till the ampulla of Vater. Ampulla of Vater is the one where it is ends. The common bile duct ends the second part of duodenum. In this area, if something is causing, that is called post-hepatic jaundice. I hope it's very clear. Hepatic, pre-hepatic and post-hepatic. Next. Further, hepatic jaundice is of two types. The pre-hepatic is nothing but unconjugated hyperbilirubinemia. The hepatic jaundice further is of two types. One is infective cause, second is non-infective cause. Very commonly seen in practice. These are the conditions which we get in practice. One is infective cause, second is non-infective cause. The infection can be of two types once again. One is active infection, second is passive infection. What is infection here? It's not bacteria, my dear friends, it is a virus. Hepatitis A, B, C, D, E, God knows when Z will come. Till we have E, A, B, C, D, E. This is very commonly seen in practice. Hepatitis A is not dangerous, self-limiting, easily seen in all the areas. It's once again seen in slum area, contagious. Once comes, it spreads in many ways because of contaminated water and food. Hepatitis B is very dangerous. Once upon a time, when I was doing my PG, it was told 300 times dangerous than AIDS. Hepatitis B is 300 times dangerous than AIDS was a slogan when I was doing my PG in the year 1997. That much dangerous this disease. And hepatitis C, rare in India, it's called malignant hepatitis, more commonly seen in US. Hepatitis D cannot occur singly. Hepatitis D will occur only with people with B. B and D stay together. This is about in brief. Now, what is active, what is passive? You might have seen in practice, many people, they do come, sir, I'm Bili Kamade Getri. Bili Kamade. What is Bili Kamade? Kamade is a low, but why Bili Kamade then? Is a carrier stage of all viral hepatitis called Bili Kamade. Clinically, the person is asymptomatic. Clinically, you cannot make out he or she is having any condition, any clinical features, but they are harboring the virus. They are carrying the virus, and this virus, during this process, is inactive. It's not multiplying. It's not replicating. When it starts multiplying, it distorts, where multiplication takes place? In the hepatocyte. In the liver in general, hepatocyte in particular. When it starts multiplying, it wants to increase the santati. It wants to increase its population. That time what happens? It starts destroying the hepatocyte and the viral load will increase. And because of multiplication process, the destruction of hepatocyte, it creates a condition called hepatitis. What is hepatitis? Inflammation of the liver in general and hepatocyte in particular. And that is called active because the viruses are active. They are multiplying. That is called active hepatitis. In that condition, clinically you can make out person having jaundice. Ictus is present because multiplication, liver is inflamed. But in passive, liver is inactive. Liver is not, virus is inactive. It is not multiplying. Simply it is eating and sleeping. Finish. It is not multiplying. No multiplication, no liver damage. No liver damage, no clinical features. That is called passive. That is called Bili Kamade, Pandra jaundice, whatever it is. Yes, this is infective hepatitis. The next, very important cause worldwide. C2H5OH induced liver disease. You might have seen many people, hepatologists, they write C2H5OH, don't write, or ethanol induced alcoholic liver disease, ALD. 90% of the cirrhotic patients in India and all over the globe, they have alcohol abuse as a primary cause for their given cirrhosis. It's very commonly seen condition that is non-infective hepatocellular jaundice. It can see, one is major alcohol, second is drug induced. First, let's see alcohol. The alcohol induced hepatitis, very common. Initially, it may be steatosis. What is steatosis? The first lecture you heard from Kulkarni sir, fatty liver. Fatty liver is steatosis. Accumulation of fat is called visceral fat. The fat getting accumulated in the external surface of the viscera, liver. It is simple steatosis because there is simple accumulation. If further same continues, nidana is continued, there is patient negligency, nidana continued, the further stage will come, what is called steatohepatitis. Steatosis will lead to steatohepatitis. Once again, the further next stop is fibrosis. The next stop is cirrhosis. The next stop is Ram Naam Satya hai. Steatosis, steatohepatitis, fibrosis, cirrhosis, Kailas Express. These are different stages. And what is the basic, what is the push, what is the sanchaya? Chayo ruddhi swadhamneva. Where? Alcohol. Kopastu unmargagamitvam. Further it goes. Then sanchaya, then prasara. Kupitanami doshanam sharidaya paridhavata. Yatra sangakha vaigunyascha. Vadistatrupajayate. That's how it begins. And it spreads and it ends. That is then. The second example or reason for non-infective hepatitis is drug-induced. Drug-induced, there are many drugs which can cause liver toxicity. And very commonly seen in practice, paracetamol-induced drug toxicity is very commonly seen. Long-term, like consumption of paracetamol can lead to this. And the people, those who are taking AKT, what is AKT? Anticox treatment. People who are taking, they are more likely to suffer from drug-induced hepatotoxicity. Very commonly seen. The people come to your clinic, for yellowish discoloration. If you take the history, yeah, the poor village people, if they come, they many times it so happens here, they are not aware of this toxicity. Kamanagetri or Kavil Zale, they come, they say, and we take the history, they say, now he had some COX, he or she took treatment, taking treatment, and that is a drug induced. Hence, detailed history is very essential before you begin the treatment. That's why Rogo Madhav Parikshayat. This is another type of, hence, the hepatocellular jaundice can be of two types, infective, non-infective. They are further classified into these. It's very clear. Next. Third, post-hepatic jaundice. Post-hepatic jaundice is called obstructive jaundice or surgical jaundice. Obstructive jaundice or surgical jaundice, it can be of three types. Here, the obstruction is going to produce in three ways. The one, intramural obstruction. Second, extramural obstruction. Third, inside the wall. If where the pathology, the respective name. What is mural? The lumen. You take a pipe. If something obstructing internally for the flow of srotovahi dravya, because of obstruction, the dravya is not flowing. It is intramural obstruction. Very common condition seen in practice is gallstones. Gallstones, pittashmaris are the best example for intramural obstruction, provided if they have entered a cystic or bile duct. If they are only in gallbladder, no obstruction. If all gallstones are not causing obstruction. See, 90%, all of us are sitting, if you go sonography, 70% will be having gallstones, I can assure you. Because of lifestyle, gallstone has become very common. But clinically asymptomatic. No need to worry at all. If it dislodges from its normal place, gallbladder enters, it starts moving, then it can cause obstruction. That is called intramural obstruction. The second, extramural obstruction. Something obstructing externally, exerting pressure, and because of that, the lumen is narrowed or obstructed and is obstructing the flow of the srotovahi dravya, that is bile. What is the best example? Any neoplasm, any growth. The best example seen in practice is CF head of pancreas. If elderly people with deep jaundice comes to your clinic, first point, one should suspect clinically it may be CF head of pancreas. Do sonography and see. Do alpha fetoprotein. Do some tumor markers and see and diagnose it. Elderly people with deep jaundice, most important cause is CF head of pancreas. That is extramural obstruction. Now, the third one, rare, inside the wall. If congenital atresia of the bile duct, the bile duct is not patent, it's closed because of deformity of the wall. Infantile cirrhosis, biliary cirrhosis, very commonly seen in children. That is inside the wall. Hence, in this way, the obstruction can be of three types. Something internally obstructing, something externally obstructing. There is a congenital atresia. These three things can cause extrahepatic jaundice. That is the important, these causes. This third classification. Next. Now, further, for make it simple, I have classified, this is my contribution. Obstructive jaundice can be of two types. One is intrahepatic obstruction, second is extrahepatic obstruction. Why I am saying, because after discussing Samprapti, I will tell you why I made this classification, what made me think of in this way. The obstructive, intrahepatic obstruction, extrahepatic obstruction, and ultimately, just as I mentioned here, the take-home message for you people, jaundice can occur because of two reasons. One is destructive cause, one is obstructive cause. The destructive cause is called non-obstructive cause, second is obstructive cause. These are the only two pathologies seen in. And Chikitsa, rightly Charakachara told Chikitsa for these two conditions. He has mentioned only two types, and rightly he has mentioned. The universal truth is that jaundice can occur because of these two reasons only. Because of obstruction, because of non-obstruction. Next. Now, it's a final slide for classifications to conclude Ayurvedic classification and modern classification. In single slide, I have tried my level best to take to summarize the classification for students. Modern believes there are two types of jaundice. What are those? Predominantly unconjugated hyperbilirubinemia and predominantly conjugated hyperbilirubinemia. This is the first classification. The next modern classification is hepatic post-hepatic and pre-hepatic. And next, the reasons. The next, the Ayurvedic classification. Now, all unconjugated hyperbilirubinemia are pre-hepatic jaundice. Nothing but Koshta Shakha Ashita Kamala according to Ayurveda. This is take-home message. The Chikitsa of Koshta Shakha Ashita Kamala, what our Acharya has been told, has to be adopted for this condition only. It's basically specific to this condition, not for that condition. Tatra Pandvamai Snikdai Tikshne Urda Anulovakaihi Samshuddho Murdubhi Tikdai Kamalitu Virechanaihi Rechanam Kamala Arthasya Kamala Sneha Sadhu Prayojat. All these are basically for this, not for that. Conjugated hyperbilirubinemia is nothing but it can lead to either hepatic jaundice or post-hepatic jaundice because of these two reasons, and in Ayurveda it can be considered as Shaka Ashita Kamala. Now, this is non-obstructive jaundice. This is non-obstructive jaundice. This is obstructive jaundice. Non-obstructive jaundice is Koshta Shaka Ashita Kamala. Non-obstructive jaundice is Koshta Shaka Ashita Kamala, and obstructive jaundice is Shaka Ashita Kamala. I think it's very clear. To make it more clear, I'll tell you the Samprapti. Next. Yeah, this is just now I was telling. It is Dr. Samir Naik's classification. It's nowhere is available. I have classified Shaka Ashita Kamala into two types. One is Swatantra Shaka Ashita Kamala. Second is Paratantra Shaka Ashita Kamala. This is my contribution after studying in deep this disease. I'm studying this disease since last 30 years. When I had started my journey as a BMS student in the year 1992, since then I am thinking of this disease. This is my contribution, I can say here. The obstruction can be of two types, and one is Swatantra, second is Paratantra. Swatantra is Aushadhi Sadhya. Why I made this classification? Because Charakacharya strongly believes Shaka Ashita Kamala is Aushadhi Chikitsa Sadhya. Shaka Ashita Kamala is Aushadhi Chikitsa Sadhya. Just now I compared all obstructive pathology Shaka Ashita Kamala. Then you can ask me, what about gallstones, sir? What of CF at the pancreas? Is it reversible with medicine? No. But unfortunately, our acharyas have not mentioned any Shalya Chikitsa, surgical Chikitsa, Shastra Chikitsa or Kamala. We don't have any reference at all. That's the case. It is not our bread and butter where it has to be referred. And that is Paratantra Shaka Ashita Kamala. Paratantra, because of some Paratantra obstruction, Paratantra Akramana obstruction has occurred. Intrahepatic obstruction is, I'll discuss in Samprapti what is intrahepatic obstruction. Here, it's like for this moment, you just take it. Shaka Ashita Kamala is of two types, Swatantra and Paratantra. Swatantra is hepatic obstruction, Aushadhi Sadhya. Intrahepatic obstruction is Swatantra. Extrahepatic obstruction is Paratantra. Next. Samprapti. I hope I will not go in detail about Samprapti. Pandurogiyo attartam pittalani nishevate tam asruk mamsam tagdva kamala rogaya kalpate. Kafasamurchato vayu sthanat pittam kshipet balim. Two Samprapti stored for Shaka Ashita and Koshta Shaka. Next. This is next. Yeah. This is once again my innovation. Since almost wherever I go, I keep on showing this. So I am making Charaka's shloka in diagrammatic presentation. One is Pandurogyo Attartam Pittalani Nishevate Tam Asrag Mamsam Dagdva Kamala Rogaya Kalpate. Koshta Shaka Ashita Kamala. Here what is the Nidana? Asrag Dagdva. The word Dagdva is Sandushana. Madhukosha commentary, if you see in Madhava Nidana, Dagdva iti Sandushanat. It can be taken as breaking. Who is undergoing breaking? Rakta, Asrag. RBC breaking, we can say. Because of excessive destruction of RBC, more Malapitta is produced. Rightly, Chakrapani has mentioned this Kamala as Bahupitta Kamala. Koshta Shaka Ashita Kamala is also named as Bahupitta by Chakrapani. Why Bahupitta? The quantum of Pitta available in Koshta is excess. Here, more production, more conjugation, more excretion. That's why the quantum of Pitta available in Koshta, Bahupitta Kamala. This is Koshtashakarshita Kamala. Kapha Sammurchato Vayu Sthanat Pittam Kshipet Balim. Shakarshita Kamala. Kapha and Vayu, because of its own nidanas, Charakacharya has mentioned specific nidana for Shakarshita Kamala. Ati Vyayama, Ati Vivaya, Ruksha, Snigdha. Because of this, Kapha and Vata, they get Prakupita. This Prakupita Kapha is going to produce Avarodha. Because of this Avarodha, you know already, Vata gets Prakupita because of two reasons. The universal reasons I say. One is Marga Avarodha, second is Dhatu Kshaya. Already Vata gets Prakupita because of Nidanas, gets further Prakupita because of Marga Avarodha. This excessive Balishta Vayu, what it does, it takes Sthanika Pitta to Shakha. What is this Nidana? First year students, second year students, Ashaya Pakarshaka. You learned in Nidana classification, Ashaya Pakarshaka. What is Ashaya Pakarshaka? We give you this example, best example. The Pitta leaving its normal path, going into abnormal path. Ashaya Apakarsha. And who is doing? Vata. Because Vata is only having Gati. And here in the Samprapti you can make out here. The Prakupita Vata takes Sthanika Pitta to Shakha. Here Kapha and Vayu are producing Avarodha. That is obstruction. Back. Because of this Samprapti, this made me to think all obstructive pathology are Shakarshita Kamalas, also called Ruddhapata Kamala. This is also called Ruddhapata Kamala by some acharyas. Because of Avarodha, the Pitta remains in the liver. What do you call this condition? Cholestasis. I hope all of you have come across the word called cholestasis. What is chole? Bile. Stasis, stagnation. Why? Obstruction. Where obstruction? The bile canaliculi. Just now I mentioned you. The first aperture for the excretion of the bile gets inflamed, gets blocked. What is hepatitis? What's happening here? It may be infective hepatitis, non-infective. What is happening here? What is inflammation? It's the inflammation of liver in general and hepatocyte in particular. The liver undergoes severe swelling, and because of that, hepatocyte swollen, and because of swelling, the excretion aperture gets blocked. This is Kapha Sammurchato Vayu. This is Kapha Sammurchato Vayu, the blocking, and because of that, the Sthanika Pitta is going to Shakha. That is Samprapti. Hence, because of obstruction, the Pitta which is supposed to reach Kosta is not reaching, it is going to Shakha. Hence, the quantum of Pitta available in Kosta is very Alpa. That's why Chakrapani has mentioned this as Alpa Pitta Kamala. I hope Bahu Pitta, Alpa Pitta is very scientifically told by Chakrapani, and I made it more picture presentation. I wanted to make it picture presentation. What is Alpa Pitta, Bahu Pitta with the help of this slide. Next. Yeah, to conclude. Now, the roots, what you see, Raktavasrotas. Raktavasrotas, one big root is Yakrit, one big root is Pliha. Yakrit, Pliha, they have moolas. When it gets affected, a small sprout will come, a small sprout, the seed sprout, easily removable, but we are neglecting it to grow. When it gets Nidanas, further it grows, the first branch it gives called Kamala. Next further Koshta Shakarshita Kamala, then Shakarshita Kamala, Halimaka, Panaki, so on, different branches. One fine day it comes with big fruit called Kumbha Kamala. The tree, well-rooted big tree comes, Kalantarat, Karibhutat, Krutchasyat, Kumbha Kamala, nicely told. If Kamala is neglected, Kalantarat becomes very chronic. Karibhuta, the organ becomes Kari, nodularity, cirrhosed, fibrosed, leading to condition, incurable condition called Kumbha Kamala. It's an incurable stage, reaches, and like the big tree. When it was in a sprouted form, simple Kamala, we neglected it. Alcohol, don't drink alcohol, didn't listen. Nothing is going to happen. Consumed alcohol, Nidana, the liver, consumed alcohol and grown like a Vishamara. That is Kumbha Kamala. I hope the simile, to conclude diagnosis part, I have given this simile. Next. The clinical features, I am running late, I will go bit fast now. The clinical features, Lakshanas, I will not go in detail. Krishna Pita Shakrunmoto Bhekavarno Hatendriya Kosha Shakashita Kamala. Next. See, these are the areas, just I mentioned. Once again, I want to repeat what these are. Krishna Pita Shakrunmotro Pita Netratwak Nakhananaha. Different. Next. See the ictus. Classical. You can see this is how the one has to see the ictus. Next. See here, by doing like this. Next. Next. This is the palate where the discoloration is observed. Next. 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 Tvak pitata in fair individual is very clear, very clearly visible. Wherein here in the when we admitted patient was very like yellowish painted patient. Here in photograph it's a bit dull. Next. Most important. Whenever you're treating Kamala Rogi in patient, don't see only patient, see his or her mutra also. The mutra varna will give you exact clue what treatment has to be given. Hence, daily make it a point, morning sample, ask the patient to collect morning sample and see daily the color. What we are practicing in Belgium, everywhere. I am practicing since almost 30 years. This practice I continued. Wherever I go, I recommend this. This will give you correct picture. Apitta raga shakruto vayushcha prashmat boyet nivruto padravasya purokto kamaliko vidihi. This is. Don't see only stool color. The urine color is equally important. Next. See the urine color, how dark it will be in jaundice. It is presence of what? Bile salts and bile pigments. Next. Yes. Yeah. Shakashita Kamala. The clinical phase Shakashita Kamala. One feature I want to very highlight. Tilapishta Nibavarchaha. What is Tilapishta Nibavarchaha? The stool color in Shakashita Kamala is Tilapishta Nibavarchaha. Charakachara, so scientific, just see. It's homework for you people, those students. Why Charakachara is only for Tilapishta? Why he recommended Tilapishta? If Shweta Varna, he wanted to tell so many pushpas, white color, so many similes would have been available. Why is Tilapishta he has mentioned? His homework, you take a mushti tila and crush it and see how the kalka looks. No doubt, the kalka looks clean color, but see the consistency. How it is? Oily. Oily, the presence of oil in tila, the oily consistency and the color, clay color, both Charakacharya wanted to say in single word thousands of years back. He could able to sense because of alpa pitta, shakashita kamla, kostasya malaranjaka pittasya abhavat. Hence, there is stool will be snigdha. He could able to see the fat is not getting digested that era only. He was aware of this. It shows. So who is scientific now? The modern people say this condition clay color stool, but we say tilapishta nibavarcha. In single word we say not only color, we say fatty stool called stitoria. The word stitoria and clay color both are denoting in a single word called tilapishta nibavarcha. Kostasya malaranjaka pittasya abhavat. What is malaranjaka pitta? Stercobilinogen. I'll not go in physiology because I'm lacking time. Stercobilinogen is the end product of bilirubin, uro and stercobilinogen. Stercobilinogen is excreted to the stool and stercobilinogen is responsible for the normal varna of stool. Normal golden yellow color of the stool is because of presence of stercobilinogen. If no bilirubin, no stercobilinogen, stool is tilapishta nibavarchaha. That is samprapti. Important lakshana. The another lakshana which we neglect is jvara. Jvara is one of the lakshana told in Shakashita Kamla is indicative, it may be infective hepatitis. Generally you see infection hepatitis A, B, C, D, active phase. When you ask the patient how it begins, what is the pre-icteric phase clinical features? Jvara. Initially it's severe jvara, myalgia, arthalgia, loss of appetite, everything. Hence the jvara lakshana lightly mentioned by Charaka in Shakashita Kamla lakshanas. Next. Yes. Till now, we discuss clinical diagnosis. I told Roga Madhav Parikshayat, the clinical diagnosis. Now, before I start discussing lab investigations, one like tip for you for diagnosis. All jaundice, it may be pre-hepatic, hepatic and post-hepatic, look same. All are having ictus. Can we differentiate clinically without any investigations? It can be. Ictus is of two types. One is lemon tinge, second is orange tinge. I think just imagine lemon and orange in front of eyes. You can differentiate these two. Lemon tinge and orange tinge. Lemon tinge icterus is generally observed in case of all pre-hepatic jaundice. All pre-hepatic jaundice, the icterus is lemon tinge. If the icterus is just like a lemon, limbu, it is pre-hepatic, it may be pre-hepatic jaundice. If icterus is orange, deep yellow, it is hepatic jaundice or conjugated hyperbilirubinemia. That's a clinical tip for students. Now, the major, one of my title topic, understanding LFTs. Lab investigations, next. What generally we prefer? CBC, LFT, gamma GT, PT, viral markers, renal function, serum amylase, lipase, lipid profile. It's not compulsory each and every patient should be given all this big list, like a Kirana list. It's not happening now. The patient comes to your OPD, before asking what is your name, you write all the investigations, just get it done, then doctor will meet you in the afternoon. The morning patient goes. That's a trend going on. It should be need-based of patient, not laboratory fellow. He needs because we are sending not the cashier. What patient needs, that only we have to do. Yes, here we can think of these many tests for diagnosis. I am only highlighting about LFT today. Next. LFT. If you write LFT, the technician is supposed to do serum total bilirubin, so serum direct bilirubin, indirect bilirubin, SGOT, SGPT, alkaline phosphatase, total protein, albumin, globulin, and AG ratio. These are a test. If you write LFT, we won't write all the components. We simply write LFT. If you write LFT, serum total bilirubin, direct bilirubin, indirect bilirubin, SGOT, SGPT, alkaline phosphate, total protein, albumin, globulin, and AG ratio. Each one is having its own significance in the diagnosis. I am discussing in 5 minutes. Bilirubin is of two types, direct and indirect. What is the role of bilirubin in LFT? Many times, patient mother brings their children. Doctors look, his eyes are looking yellow. His eyes are looking yellow, is he having jaundice? Because very commonly, the patient diagnose themselves before coming to us. If you ask patient what's happening, jaundice agit sir. They tell direct jaundice agit anta hedara. Kavidi zala sir manu sangta. Doctor, they give diagnosis only. They don't do clinic. That common diagnosis, that easy diagnosis, the diseases. The mother will bring the children. Eyes are looking yellow. If eyes are yellow, if elective normal, no hyperbilirubinemia, no jaundice. Simple eyes are yellow is not sufficient. It may be some pitta prakopa lakshanas. Some pitta prakopa lakshanas, eyes. If bilirubin is high, then only jaundice. Yes. Hence, what is the role of bilirubin LFT? Whether given condition is jaundice or not. The bilirubin level, if high, it is jaundice. If no high, it's normal, no jaundice, even though eyes are yellow. Next. Yes, eyes, bilirubin is high. Another point, many times it so happens, the normal level is 0.2 to 0.8 milligram per deciliter. The given patient bilirubin is 1.2 milligrams, but clinically no icterus. Clinically no icterus. Is it jaundice or not? Yes, it's hyperbilirubinemia, pre-icteric phase. It is called pre-icteric phase. Before icterus formation sets in. The bilirubin is high, no icterus, it is called pre-icterus, before icterus. To see visible bilirubin clinically, it should cross 2.5 milligram per deciliter. If it crosses 2.5, then eyes will start becoming yellow. If eyes are yellow, clinically you can think, yes, bilirubin is more than 2.5. The test will reveal, no doubt. If eyes are normal but still high, called pre-icteric phase. Hence, the total bilirubin in LFT, what it suggests, is it jaundice or not? Next comes direct bilirubin and indirect bilirubin. What is total bilirubin? It's a combination of direct and indirect or conjugated and unconjugated. In the total bilirubin, who is contributing more? The respective name. Whose votes are more? Their government, is it not? Like that, bilirubin is a government. But who is ruling? Because conjugated says, my share is more, sir, I am 80%. That's why it's a conjugated government. If unconjugated is high, what? If both are same, Samishra Sarkar, both. Like that, The conjugated and unconjugated depends on the whose share is more and what it gives. If conjugated is high, what you can think? It may be hepatic jaundice or post-hepatic jaundice. If unconjugated is high, it is pre-hepatic jaundice. Hence, I hope the bilirubin level, direct, indirect, and total. Next comes enzymes, SGOT, SGPT, and alkaline phosphatase, and total protein albumin globulin. This I'll explain in the next slide. Go to next slide. Yeah, this is bilirubin regarding next. Yeah. See, SGPT, SGOT, and alkaline phosphatase. SGPT's location is liver only. SGPT location liver and muscle tissue. In case of liver disease, there must be simultaneous raise in both. What these are? These are enzymes which are present in hepatocyte. These are enzymes which are present in hepatocyte. The normal level is 40 international units per deciliter. Because the liver cells, after attaining its maturity, they will be destroyed, and certain amount of these enzymes will be liberated all the time into circulation because the normal destruction. Hence, the normal limit is 40 international units per deciliter. If it increases, what it suggests? There is abnormal destruction of hepatocyte. If hepatocytes are undergoing excessive destruction, SGOT, SGPT level will be high. If only SGOT is high, remaining all are normal, if only this is high, this is not liver disease. It is muscle damage. Many times, the cardiologist doing SGOT in case of acute MI within 72 hours. If acute MI occurs within 72 hours, SGOT level will be high because it's a muscle tissue damage. The muscle tissue damage. Hence, these are enzymes which are present in liver and muscle, that is SGOT, SGPT, this. These both are indicative of destruction of hepatocyte. And increased level of these are in case of hepatic jaundice. SGOT, SGPT level will be increased in hepatic jaundice. Next, alkaline phosphatase. Like SGOT, alkaline phosphatase is having extra hepatic source. It is no doubt, it is in biliary system. Then bone and placenta. In case of pregnant lady, even though she is not having any liver disease, but alkaline phosphatase is high because placenta is secreting alkaline phosphatase. Don't interpret as liver disease, no. In case of bone disorders, chronic osteomyelitis, there also we can see. Hence, it's not a liver disease. To have liver disease, to understand, to make it, to consider alkaline phosphatase liver disease, there must be simultaneous disturbance in all the components. Hence, alkaline phosphatase is basically seen in where? Biliary system. Hence, it is telling about cholestasis. If alkaline phosphatase is high, it is telling obstructive pathology. If SGOT, SGPT is high, it is telling destructive pathology. It is obstructive pathology. Then comes gamma GT, generally we see. Gamma GT is also seen in case of biliary system. Hence, alkaline phosphatase and gamma GT will tell you abnormal increase in this. There is a problem with biliary system. What is biliary system? The system which is helping for the excretion of the bile. Biliary system. Shall I 10 minutes? Oh. Next. Now, next is total protein, albumin, globulin, Ig ratio. These are telling about chronicity of a liver disease. The first, we saw the pigment part in LFT, bilirubin, total bilirubin. Next comes enzyme part. Just now we saw. Now, last protein part. The protein part, basically, total protein, albumin, we give importance for this. In case of chronic liver disease, the total protein is less. Albumin is less. You can see cirrhosis of patients. If you're treating cirrhosis, or we concentrate, keep on monitoring total albumin. If albumin is less, we have to supplement. Samanya Murtikarakam. Albumin, giving albumin injection is Samanya supplementation. We're increasing it. Dhatu Vruddhi. Hence, in case of, protein segment will tell you, is it chronic disease or not. In case of chronic liver disease, this segment is disturbed. Next. Yeah, this is what we saw just now. The hyperbilirubinemia, hepatocellular obstruction and jaundice, or then chronic liver disease. This is how the LFT is understood. Next, last investigation, urine routine, urine bile pigments, bile salts, urobilinogens. Presence of urine BP, BS positive is Shakashita Kamala. Presence of urine BP, BS is Shakashita Kamala. If at all you want to start Snehapan and Kamala, make it a point, your urine BP, BS must be negative. That is Apittaraga Shakruto. The urine becoming urine BP, BS negative, there is a point, till that point, don't use Snehapan and Kamala. This is not Charakachar has told, this is I am telling. This is what practically I observed. It's not only stool color, it is urine color also important. Urine color by means negativity of urine BPBS and negative. Urine BPBS must be negative before we start Snehapana and Kamala. Next. Chikitsa. Yeah. Whatever circus we did to do this till now. The diagnosis name circus we did till now. The clinical diagnosis, lab diagnosis. Now let's see the $1 million question, what treatment we can give, because all are eagerly waiting, what treatment? Someone asking leave 52, some 86, some 96, I don't know exactly. But I am strong believer of Charakacharya. I never believe in 52 or 66. Only 5 drugs, I'll tell. Chikitsa. Next. Tatra Pandvamai, Snigdai Tishnai, Urda Analomakaihi, Samshodo Murdbi Tikte, Kamalitu Rechanaihi. Charakacharya. Chikitsa 16th chapter. Rechanam Kamalarthasya Snigdha Sadho Prayojet. Tata Prashamani Karya Kriya Vaitena Janata. Remaining authors. The 2 Chikitsas available. One is strong Charaka's version. Second is remaining authors. What Charakacharya believes? Tatra Pandva Mai, because Pandu and Kamala is discussed in a single chapter. There is a Pandva Mai. Snigdaihi, Tikshnaihi, Urda Analomakaihi, Samshodyo, Murdubhi Tiktai, Kamali, Tu Virechanaihi. Rechanam Kamala Arthasya. Hence it is Virechana. The strong line of treatment for Kamala is Virechana because Kamala is a Pitta Jananatmaja Vikara, Pitta Pradhana Tadosha Vikara, Raktava Srotogata Vikara, hence Virechana, likely choice of Shodhana. Chikitsa, my dear friends, Ayurveda believe there are only 2 chikitsas. What? Santarpana and, yes, there are only 2 diseases, Santarpana, Apatarpana. I don't know Kamala Pandu. I know only Apatarpana disease, Santarpana disease. For those, it is 2 type chikitsa, 2 vadis only. Further, now let it, that takes another half an hour for me to go in basics. Let it, I am discussing this. Tatra Pandva Mahi, this chikitsa sutra is for Koshta Shakashita Kamala. Remember, my dear students, whatever Charakacharya is telling here, it is only for Bahupitta Kamala, Koshta Shakashita Kamala. He has told Rechanam, he has not told other Acharya, Rechanam Kamala Arthasya Snigdha Sadho Prayojet. It is not Sadhyo Shodhana or Sadhyo Virechana, it is Virechana Karma. Purva Karma Adi, Purva Karma, Pradhana Karma, Paschat Karma, all will be there in this. Purva Karma, Virechana. What is Purva Karma? For Shodhana? Yes, Snehana, Svedana, Rogi Tapasana, Rogi Parikshana, Sambhara, Sangra, so on. Here, the Rogi is fit. First, always one should see whether Rogi is fit for given condition. Akshina Balamamsa. The standard shloka, standard word. Akshina Balamamsa. Roga Bala, Rogi Bala must be supportive for Shodhana. Roga Bala must be Pravruddha dosha in Kosta. And Rogi Bala can sustain the Shodhana. Akshina Balamamsa. To see whether the given patient is fit for Shodhana or not. Yeah, fit. Next. Do Agni Deepana, Amapachan, because Snehapana cannot be done in Amavastha. In Amavastha, don't give Snehapana, it will agree with the Samprapti. Agni Deepana, Amapachana. Once the Deepana Pachana Lakshanas are observed, then we start Snehapana. See, generally, Shodhananga Snehapana, Abhyantara Snehapana is of 2 types, Shodhananga, Brahmananga and Shamananga. The need-based, purpose-based, Karmokata-based classification. Based on Karmokata, the respective name has given. If it is Shodhananga, before Shodhana, Doshotleshana, the Artha, that is Shodhananga Sneha. Shamananga, Vyadi Shamana Artha. Brahmananga, to increase the Brahmana, to attain Brahmana. Brahmananga Sneha. Here it is Shodhananga Sneha. The Shodhananga Sneha is of 2 types. One is Sadhya Sneha, second is Arona Karma Snehapana. Here, if you see Charaka's version, Pandu, Kamala, Udara, all these are Nati Snigdavat. Whenever you're doing Snehapana, we keep monitoring. We monitor the patient for what? Sneha Jirana Lakshana, Sneha Jiryamana Lakshana, Samyak Snigdha Lakshana, all these. Samyak Snigdha, is it not? We continue Snehapana till the appearance of Samyak Snigdha Lakshanas. But we don't want Ativa Snigdha Lakshanas like Aronakrama Snehapana. Kamala is Nati Snigdhavat. Ativa Snigdha is not required, not desired. Hence, Isha Snigdha, Alpa Snigdha Lakshanas can be achieved by means of Sadhya Sneha. There are different thoughts of different schools from as per Sadhya Sneha is concerned. First day we give Rusyasi Matra 30 ml, then give 50 to 70 ml, then 150 ml. This is what we practice. 3 days Snehapana we do. Satya Sneha. Which Sneha one must be used here? Charakacharya is Panchagavyam Mahatiktam Kalyanagata Piva. He has told so many Aushadhi Krita Kritas. But Sushruta Dalana is very clever. Plain Gavya Gruta can be done. It can serve the purpose. What is that? Murchita Gruta can be used. Hence, what Sneha can be given for Snehapana here? Either Panchaktikta Gruta, Kalyanaka Gruta, Dadimadi Gruta, or if you don't have anything, plain Murchita Gruta also can be used for Snehapana. Isha Snigdha I told, it is done for Alpa, it is done till we achieve Alpa Snigdhata. Next, after that, Vishramakala, because we are doing Virechana, we have to give Virechana Ushadi, Triratro Pari. Some people interpret 3 days, 4 days, 2 days, let it. After appearance of Samyak Snigdha Lakshana, Triratri, we have to wait for next Shodhana. Triratro Pari. For during this case, what we do? Sarvanga Abhyanga and Sweda we do. But Kamala is a Pitta Pradhana Vikara. Hence, Mahasweda, Tikshna Sweda is contraindicated. We can't do Tikshna. We don't push the patient into steam chamber and give full Sweda. Don't give. It is Alpa Sweda. Or it's mild Sweda can be given. That is Anagni Sweda you might have learned. Ushna Jalasnana, Guru Pravarana. Anyone can be done. Anyone can be considered. That is Sweda. Then Vishramakala, then you know what food must give during Virechana. The respective food is given. This is done for 3 days. Then final day, Virechana. What is Virechana? Mrudubihi, Tiktaihi, Kamalitu Virechana. It must be Mrudu Virechana, not Tikshna Virechana. Tiktara Sapradhana Ushadi Siddha. Mrudubihi Tiktai, Kamalitu Virechanaihi. Mrudu Virechana. Don't give Jayapala something, Icha Vedi something. No, it's Mrudu Virechana. Tiktara Sapradhana. It is either Katuki or Karavellaka can be used. But in general, it's a universal drug we use. What is that? Trivurtlaya. Trivurtlaya is universal drug for Virechana. It's immaterial what disease we are treating, but very easily available. We use it. But what classic says, what Charakacharya says, it should be Tiktarasa Pradhana. Hence we use, I understand Tiktarasa as either Patola, Karavellaka, or Katuki, Picrorhiza Kurova. These drugs can be thought of. Do Virechana. After Virechana, what? Paschat Karma. Paschat Karma, we have to first thing what we have to observe, is there any Vyapat? Vyapat, any complications? Here complication can occur in because 3 reasons. Ayogajanya Vyapat, Atiyogajanya Vyapat, Mithya Yogajanya Vyapat. I will not go in detail. Any Vyapat, just treat Vyapat. This is Virechana. Next. Next, fast now. These are drugs just I mentioned here, what one can think of. Next. Next, yeah, important chikitsa, most neglected chikitsa, Anjana and Nasya in Kamala. We have 2 chikitsas, Anjana and Nasya, Dronopushpi Anjana. Next. Anjanam Kamalarthanam, Dronopushpi Rasam. Here, Dronopushpi Kalka is prepared, smeared in an iron pot, 24 hours left, then scrape it, and Anjana Varti is prepared, used for Anjana. We have Nasya also told, very Mic working?
Hello.
Hello, it's working now. Shakashitaka Amla Chikitsa. Charakacharya is very clear. Nowhere he has mentioned any snigdha ushadis. Ruksha, Katu, Tikta, Amla, Barri, Titri, Dakshanam. He has told. Shushka Mulaka Yusha, Matulunga Yusha, Kulatta Yusha. See, so beautiful, like so scientific nature of Charaka. Nowhere he has mentioned. He has told, just no, bring the dosha from Shaka to Koshta. Vrudhyat, Vishandanat, Pakat, Shaka Mukta Malam Yanti. Yes. To achieve this, we have to I use in practice Trikatu Churna with honey and lemon juice. This is sufficient. Whenever cholestasis patient comes to you, don't give any costly medicines. No need to give any costly medicines. Give only Trikatu Churna 5 grams, 5 ml lemon juice, 5 ml honey. The combination, make it, ask the patient, lick it once a day on empty stomach, early morning. You may ask for how many days one should give. Apittaraga shakruto vayushta prashmat bhavet. Nivrutta upadravasya purokta kamaliko vidihi. This is continued till the stool attains normal color. Because of shaka, avarodha, the pitta, instead of entering shaka, koshta, it has entered shaka. Because of that, the mala is tilapishta nibhavala. Once this tilapishta goes, the pitta starts coming naturally, normally to the stool becomes normal, then you can think of purokta kamaliko vidihi. Tatra pandvamai snigdai tishne urdhanulomakahi. Now you start snehapana. Now you tell now who is scientific. Many modern doctors, they ask us, you Ayurvedic people say so many Ghrita Yoga, so many fat in jaundice. How can you advocate fat in cholestasis, in jaundice? No doubt, in Ayurveda we believe also same. Charakacharya, the great physician of our system, has accepted, has told thousands of years back, in cholestasis, don't give fat. You give only tikta, shushka mulaka yusha, kulatta yusha, bari titri dakshanam, mamsarasa. See, Charaka was so, he was so brilliant he was. He could able to see, he was very diplomatic. He didn't disappoint the non-Western people also. If you want mamsarasa, use barri, titri, daksha, pranis. Don't eat strong other prani mamsarasas. If you're vegetarian, then shushka mulaka yusha, kulatta yusha. All these use till the pitta starts coming to kosta. That is shaka ashita kamla chikitsa. Then last, once the stool colors become normal, just now I mentioned here, in case of jaundice, if at all you want to do snehapana, my dear friends, urine BP, BS must become negative. That is take home message. It is not mentioned in any text, any samhitas. It is my observation. I am saying in the practice. If you want to do snehapana in Kamala, urine BP, BS must become negative. Urine becomes normal, and that is fit for snehapana. Once then, do sadhya sneha, do virechana, then kriya vaidyena janata, whatever like shamana ushadi you want to give shamana ushadis. Now, the chikitsa is incomplete if I don't discuss pathya. Any chikitsa, if you write everything like with big shlokas, 4-5 pages, if you don't write pathya, you lose 2 marks in the exams. Hence pathya. Samshodhu kamalitu virechani, what? Sa yava godhuma purana shalin, mudghadaki masurascha jangalesha rasahitaha. So nicely as told. In each and every step, I had told how Charaka was scientific than these modern people. Now last to conclude, there also I will say you. What generally modern people say, what is the diet they recommend for liver disorders? High carbohydrate, high protein, less fat. Sa yava godhuma purana shalin. What is yava godhuma? Monocotyledons. Shuka dhanyas, rich in carbohydrates. In what form he has told? Not roti or tandoor roti he has told to give. No. What is that? Yusha samhitan. It must be given in gruel form, liquid form. Easily digestible, easily absorbable. Mudga adaki masura. What these are? Dicotyledons, rich in proteins. Then, just now once again, diplomacy of Charaka Samhita. He doesn't want to disappoint the non-vegetarians.
Jangala Prani Mamsarasa, yes, told. Yeah. One fellow asked, sir, you are advocating for all Western diets. What about me? I am non-vegetarian. How can I live? Don't worry. You can eat Jangala Prani Mamsarasa. Because the fat content in Jangala Prani is Ishat Snigdha, not Auduka or Anupa Mamsa. Now tell me, who is scientific? Is it not Ayurveda advocated high protein, high carbohydrate and less fat? Same thing Charaka just told. Hence, whatever is not only with jaundice or Kamala, it is each and every sentence told by Charaka and Charaka Samhita is 100% scientific. Believe Charaka Samhita, believe all Samhitas, definitely you will come to know how beautifully they have told. Hence, this is Chikitsa, Pathya. There are so many Shamana Ushadis can be given. Because of lack of time, I am concluding here. I use 5 drugs, Katuki, Nimba, Bringaraja, Guduchi, Bhumyamlaki. These 5 drugs I am using, this is sufficient. I am treating all type of liver disorders. My students are here, they have seen my treating all sorts of grace of God. I had opportunity to treat from simple hepatitis to hepatocellular jaundice, hepatoma. I have treated from neonates to elderly people. All sorts of cases I had seen in my practice of 30 years. I have reversed many liver cirrhosis conditions, completely cured. Actually, I have forgotten one patient, he stays in near Chikodi Taluk in Janwad. 21 years back, I treated him, he's fine. 21 years back, he was told he hardly can survive for 2 months. It is 23rd year running, he is absolutely fine. Mr. Mallikarjun Patil, he stays in Janwad in Chikodi, near Janwad, near Borgaon. Hence, we are, by considering all, recently I treated successfully Wilson disease, which is just impossible as per tax is concerned. Once upon a time, Masta Mahagada has been told, Udara is one amongst them. Now, I made it Sapta Mahagada now. I removed Udara out of that. It is treatable. Yes. I take this opportunity to thank Dr. Magdum sir, Principal sir, all the members of this prestigious institute for considering me for this today's event. I thank all the audience for patient hearing. Whatever little I learned, I know, I shared. Nothing is hidden here. Whatever I practice, I disclose in front of you. There is lot of scope. We are far better than all those hepatologists, so-called hepatologists practicing. We also do liver transplant. I had done many liver transplant, but difference between those people and my approach is I had done all liver transplant without taking incisions. I have replaced all unhealthy fibrotic liver tissue into normal healthy liver tissue by virtue of this great science. Thank you.
Thank you so much, sir, for sharing your expertise and insights with us. Really, it was a wonderful session. And we learned more things and we understand Kamala. Now, let's move on to the question and answer session. Dear delegates, please feel free to ask questions and our guest speaker will be more happy to respond. Any questions? Any questions? Okay.
Good afternoon, sir. I am from BLD AVS Ayurved Mahavidyalaya, Vijaypur. I just wanted to know the dosage and forms of the 5 drugs you told.
I use all these 5 in the form of Swarasa. I collect them freshly, except Katuki. We prepare fresh swarasa, 50 ml swarasa and 5 grams of katuki churna with little bit honey. If at all, if patient needs palatability, it can be given. I give it only once a day, early morning, after giving trikatu churna. This can be given once a day in the form of swarasa. With that, I use many other drugs because of time consent and I couldn't able to cover it. I use Trifla Nimba Guduchi Haritra Kashaya. I use Charakokta Kashaya. I use daily, because most of the cases I do treat on inpatient basis. We prepare kashaya and we dispense them. Daily 50 ml kashaya we give. Trifla, Nimba, Guduchi, Haridra, the components are. These two are just wonderful. One is Trikatu Churna, the NAB Surasa we call. If you go to Mysore, because I did PG in Mysore, Government of Mysore, it is very famous. KNABB, it's abbreviated. K for Katuki, N for Nimba, A for Amruta, B for Bringaraja and Bumjamlaki. NAB, KNABB Swarasa. Use it. 50 ml BD I use. And just now I mentioned the Swarasas and Kashayas and Trikatu Churna. This is sufficient. No need to go for 50 to 96. I hope understood.
Any questions again?
One thing, Chikitsa not giving only Shamana Ushadi. I strongly believe Shodhana, Shamana and Nidana Parvarjana, it is complete Chikitsa. Neither Shamana alone nor Shodhana alone is incomplete. A complete Chikitsa is one. It's our Yukti Pramana, which Chikitsa is needed when it's a need-based, tailor-based. We have to design Chikitsa based on the given patient. There's no standard universal Chikitsa like modern we have. We have to design. Each and every patient is challenging. Each and every patient, even though complaining same complaints, are new, are different. You cannot give same paracetamol to each how they give. We can't. We have like so many yogas told. Our Acharya is not foolish to tell so many Shamana Ushava single disease. Mrutyunjaya Rasa, Jayamangala, Jwaramangala Rasa, Tribhuvana Kirti Rasa. No, they are not finished. They are not foolish. It is, we are foolish to understand their concepts. We are not understanding it.
Sir, preventive care in hepatitis B patients. Preventive care in hepatitis B patients.
Preventive care. Preventive, madam, vaccination, first of all. Of course, how far it works, we don't know. A belief at the end of the day. We believe it's working, it works. That's one. And hepatitis C, it can spread. We know here there are different, by all body secretions, it can spread. Urine and even saliva, even the blood, no doubt. The blood and semen, they are most important transmitters. But apart from that, it can spread to all secretions. Better to avoid all physiological, pathological secretions to avoid here. That's how we can be careful, because I'm treating since 30 years. I had my research work was hepatitis B itself here during my post graduation. And for your kind information, 100 cases I studied, all 100 become seronegative after my treatment, which is just impossible. But one thing, my work was active phase. I worked on active phase of viral hepatitis. Of course, passive is a bit difficult here. You may ask carriers how long. Carriers, even carriers also I do treat, I'm treating, wherein they need medicine for 2 to 3 years, even 4, even some people are on taken 5 to 6 years also they're taking. But one thing, one important thing, take home message is, all patients, those who have received our treatment in the carrier phase, they have not landed in any complications. Very commonest complications in an hepatitis B carrier is hepatocellular carcinoma, HCC, very commonly seen in case of carriers. And not a single patient in all this my practice career, I have come across this complication. We could able to prevent complications. That's our achievements. That's our contribution you can say here.
Sir, how you approached Wilson's disease patient? Wilson's disease patient.
Disease, it's a big story, Amma. When the patient came, you can see that the people, those who are sitting in behind, just beside you, Anita and Uma, they were my students in they were doing PG, and they only used to attend in the ward. It's in 5 minutes, sir. I had taken a lot of time. Almost 15 years back, I think, when I was faculty of KLE. One fine day, one parent bring their child, brought their child. In fact, she was admitted in Lakeview Hospital in Belgium. And there, their child was referred to higher center for liver transplant. They diagnosed Sri Raksha as a decompensated liver disease with Wilson's, with cirrhosis, portal hypertension, cannot be reversed. The only remedy available is liver transplant. Her parents were from Ramdurg running a Kirana shop. They were very poor. They were not affordable. Then somehow they came to know about our institution. They came to us. Initially, it was in Kaumar Bhute department. And Wilson's with complication, they thought ki it's better to refer to Samir sir. They referred it to me. I took it as a challenge. When she was referred to referred to our department, her hemoglobin level was 6 grams. Albumin was very low. Initial 4-5 days, he was like just I mentioned here, Sarvada Sarva Bhamanam, Samanya Murdikarakam. If anemia is 5 grams, 6 grams hemoglobin comes, there's no, it's foolish if you start giving Shamana Ushadis. We directly supplemented fresh plasmas and whole blood was given. PCV were given and albumin supplementation. Once stable, she was stabilized. Then we gave her treatment. The treatment was Nitya Viration. I do treat Jalodhara a lot. In the concept of Jalodhara I treated. Today, actually I want to discuss a bit about Jalodhara, but lack of time I couldn't able to cover that part. It's a portal hypertension. For your kind information, it's a portal hypertension we do treat. Whenever you're treating portal hypertension, just giving diuretics is not sufficient. The reason is, because of portal hypertension, there is accumulation of fluid. As long as portal hypertension persists, this process is going on. I've seen many people, they undergo paracentesis. Morning, they remove all fluid. Evening, once again, tummy full, tanker. In my clinic, they name this patient tanker. Whenever they come with big tummy, sir, tanker bantre like that. And this to see, my treatment, our treatment, that's not my, I never use the word my, our treatment is removing portal hypertension. That's how we succeeded. For that, I do Virechana. I classify Virechana in 4 categories. Tikshna Virechana, Ruksha Virechana, Ruksha Tikshna Virechana, Snigdha Virechana, Snigdha Tikshna Virechana. These 4 varieties I practice. Ruksha Virechana giving Haritaki Churna with Ushna Jala alone, depending on the conditions. If PT level is high, albumin is very low, if esophageal varices are very big, chances bleeding is there, then don't give Tikshna like Gomutra. Tikshna is Gomutra here. Don't give Gomutra. Condition for giving Gomutra, make it a point all the time, my dear students, whenever treating chronic liver disease, keep on constantly monitoring PT level, albumin level, and HB and platelets. These are very important. If they are supportive, then we can do all miracles. If not, very difficult. Patient will end up with complications, HRS, hepatorenal syndrome, hepatoencephalopathy, and so on. Saraktakshi, Vindmutra Shardi, Brusham Shunascha Manavaha, Dinaha Klanta, see if you see Charaka's version, Saraktakshi, Vindmutra Shardi, all the ways there is a bleeding, Saraktakshi, ophthalmic bleeding, Vindmutra Shardi. Goduk, the Snigdha Tikshna Virechana I followed in her. I gave it for almost 21 days Virechana. She consumed somewhere 1 liter of Gomutra in this entire period. Just imagine, 5-year-old girl consuming 1 liter of Gomutra, not in a single day, but entire course of treatment. Just see, it is a bit difficult, but she cooperated. Because of her cooperation, I could able to reverse the disease. Now this is 16th year, she is doing well. She is fine. No liver transplantation, no incision, but definitely we cured. Complete cure. The serum 24-hour copper level, the urine copper level, penicillamine level, all are, ceruloplasmin level, all are normal. She's fine now, totally cured. Wilson, which is just against the text, against the science. The only concern, I'm very poor in publication, that's why I not publish it. But I lack of like time and other things, I not publish it. But another case I'm treating now, Wilson's, I'm another treating. It can be treatable. If some time permits, you can approach me, I can tell you how I treat it.
Okay, no more questions? Thank you so much, sir, for providing valuable insights and clarity on the topic. Dr. N.A. Magdum, sir, our principal, sir, and our vice principal, sir, Vishal Chogle, sir, to felicitate, and Suresh Chogle, sir, to felicitate our today's guest speaker, Samir Nayak, sir.